go ahead. Here's some handheld or different devices by which the physician can evaluate the patient and get the stroke scale. You can be out in the field, somebody call in, you can stop, and you can do it right over something rugged like this. You could be not a cop, but you could be out on your motorcycle, just if you have large pockets that could fit it. There's also ones that you can, that look a little bit geeky actually when you look at it. But anyway, but nonetheless you can carry around and they make it portable. You can use the DVD system in the car. Yes?
I have a question on how accuracy if you compare on those devices. Like the bigger system, more accuracy, the smaller the handheld, less accuracy.
The difficulty with the smaller ones is making sure you're getting a clear and large enough image to make a good evaluation of the CT scan, and that the patient is large enough so you're not looking at a small screen like an iPod and trying to notice subtleties. So, you know, smaller is not always better, but these are methods by which it is done.
So I have a question here. So this is just a computing device?
Yes.
Assuming it has a wireless connection.
Yes.
But where is the data coming from? I mean, this is
Okay.
going to you, right? Like you are the expert who is seeing this.
Right.
Okay. But the data is coming real time from the patient's room?
Yes. They will have a computer in the room, obviously, a camera and computer. And this is, there are different systems in place. And what we're developing here with John Fultes is our own system, but there are other systems, for example, the robot one that you can drive around, that's about the priciest one out there. And to rent that, it's about $6,000 a month.
So basically, if from the patient's room I can put all the data and application on the internet, then I can be anywhere in the world and access.
Absolutely. As long as you have a little, you know, a card or a connection of some way, it can be to you. Yes.
I still have a question.
Yes.
You mentioned the importance of time, determining the time of consent. And you talked about ambulance, one of the ways of bringing them into the hospital. Is there any technology of which can be used when the patient is still on the ambulance to transmit, you know?
Well, the technology is there, but it's not in ambulances for several reasons. There's no physician on the ambulance, and there's certainly no neurologist. And ER physicians are generally wanting the backup of a neurologist before these decisions are made. And because it's potentially a litigious situation. And the ER physicians already have a lot of people that they're screening and in and out, you know, and they have to make judgments on. And this would be one more area that they have to take a higher risk. And so they want the backup of a neurologist, and there just aren't, you can't put a neurologist on every ambulance. Now, could they have the computer, you know, the patient in the room there, in the ambulance, and have somebody, yeah. The number of times that you would have a stroke patient coming in, I don't know. I guess they would have to decide if it's cost effective to put this technology in every ambulance so that they could communicate with a neurologist. Right now it's probably too cost prohibitive. But I imagine you're absolutely right. In time, when every ambulance can have this sort of equipment and it's small and it won't take up too much space, and imagine in time we'll be getting to it earlier and earlier. Okay. And we have the Paul has a machine, a vehicle that goes out with the telemedicine all in the vehicle, but it's not an ambulance.
I showed that video.
Oh, okay.
Yes.
Yeah. So technology gets cheaper and cheaper, and so soon it will get there, but this is in the early days still of telemedicine. So, and more neurologists have to be willing to accept doing it remotely. And there's a lot of resistance there too.
Yeah, you mentioned the teaching us. You know, that is, do you get to have a time when, based on the situation of how the emergency, you decide, let's do it this way and talk about the legal implications later on?
Absolutely, all the time. We have to make those decisions. There are times where for example, if we think it's in the best interest of the patient to receive the medication, that could be a matter of them being disabled for the rest of their lives versus the potential of reversing the stroke. And the patient is not in a position to be able to give us a clear consent. We believe it is the standard of care now to offer this medication. And so personally, because it's the standard of care, I would choose to make that decision as the best that I could on behalf of the patient if it was an emergency situation, and then deal with everything later. But ideally, we will talk to the patient or family and get consent in one way or another. But there are times where things aren't ideal. Yes?
Okay, I have a question for you, because there will be a neurologist, but there will be different kind of experience. The brand new one in school and the one on the industry for a while. So because you've been in the field for so long, so thinking about helping it, now how do you pass the knowledge? Like you can start on knowledge, maybe, or is there any way if they identify the patient with a stroke problem and they're not sure because they don't know the symptoms well, anything else, can they connect to you and using the video conferencing?
Certainly that would be a possibility, absolutely. And sometimes neurologists who are out in the field and who haven't been doing a lot of stroke and may not feel as comfortable with it. Actually, the brand new neurologist who's gone through training, they all feel very comfortable with it because stroke is so common. In their training, they see it all the time. And our first year residents who are just finishing their very first year of residency, they're more comfortable than our attendings because they're doing it. They're on call, they're taking care of it, they're doing it all the time.
So stroke in general is a real-time application. There is no store and forward yet. Like I was thinking of Johns Hopkins second opinion site, which is really telemedicine, but it's all, synchronous. It's not it's asynchronous.
Yeah.
But in this case, you've got to have a second opinion right now.
Yes.
Okay.
Yeah. In order to give the clot-busting medication through intravenous, you have to give it within 3 hours. And not only that, it's not, as long as you give it within 3 hours, you're going to get the same kind of results. It's the earlier you give it, the earlier on the scale you give it, the better the results.